I'm going to talk about the pharmacologic treatment of anxiety, and I guess originally it was advertised as anxiety and depression, which seems like quite a lot. If we get through this, there'll be a few words about depression. There's a huge overlap. We use pretty much the same medicines anyway, so at least as far as learning about the medication, we should be good on that. Wanted to start with a few opening remarks in general about pharmacology. First of all, this talk is going to be very idiosyncratic. It's based on my experience, 30 plus years of doing this, my continuing medical education, but like I said, it's based pretty much on my experience, the way I'm doing things. You might not want to put all the answers on your test because I may be a little different in my way of thinking. I'll try to point that out as we go along. First comments is I'm going to be talking about these medicines like everyone else does, the SSRIs and the norepinephrine, serotonin medicines, and then Wellbutrin based on its mechanism of action. But I'm really quite an agnostic about these mechanisms of action. There really isn't compelling evidence to say that depression and anxiety have something to do with serotonin. Why the serotonin reuptake inhibitors work, serotonin's part of the story, but not all the story. So I'll use the common nomenclature, but it doesn't mean that I believe in these mechanisms of actions. I still see things pretty much as a black box. These things seem to work, we use them, but really why they work, I don't know. And I think most people who really into this would agree with that. That's important because, you know, I don't want people, I have people coming with their serotonin levels drawn or their norepinephrine levels drawn. That's got nothing to do with it. They want to, know some of these, what sort of chemical imbalance I have. I don't think we can answer those questions, nor should we try. Also, these medicines don't work very well. We've got very, very bad tools in this business. There's the new thing that they like to use is something called number to treat. So give you some idea of how bad our medicines are. And this is actually going to be very favorable to the medicines and numbers I'm going to use. But in most studies, we can draw on this, right? Yep. Okay. About 40% of the people you give an antidepressant to, because that's what we're going to be talking a lot about, will get better. But almost 25% of the ones you give the placebo to will get better. So there's only a 15% difference. And the number needed to treat is you divide 10 or 1 by 15, and you get a number, and you round it off, and you get a number about 7. What that means is, if you're using a certain medicine, you have to give that to 7 people before you help 1. So that's kind of frustrating. Now, I think our medicines in the clinic work better than that. And also, we have the opportunity to try multiple different medicines, sometimes combinations. So we help more people than that. But one single medicine in research, you have to treat 7 people before, and 7's a good number. Some are even less. So once you know that about our medicines, we work now with the theory of serotonin, norepinephrine, and dopamine mostly. These are fairly rare neurotransmitters in the nervous system. Very, very common neurotransmitters are GABA and glutamate, but we haven't been very successful working with those. The benzodiazepines and Buspar work with GABA. They've got their issues. And glutamate is where it's going to be at for depression in the future. I think ketamine is part of the glutamate thing. You may have heard about that. And then a friend of mine's working on some steroid compounds that affect glutamate. So in the future, that's what it's going to be all about, because there's glutamate's the excitatory neurotransmitter that's all around, so it's going to help with depression. GABA's the inhibitory one that's going to help with anxiety, and they're so much more common and pervasive in the nervous system that they're really going to be the better medicines. So let's get on topic about the anxiety. Have you guys noticed that we use the same acorns as you guys? Do you know? Yeah. Have you ever noticed that someone can come in with an acorn and it'd be all nothing, but they have terrible anxiety because there's nothing on the acorn that addresses anxiety, even though a huge amount of our patients have it. I haven't figured that one out yet, but you get confused. It looks like they're doing great and they have tremendous anxiety because the acorn doesn't pick that up. So anxiety, I'm sure you know, is really, really common among our patients. There's seldom we see someone with depression who doesn't have some anxiety. Oh, there are those people. And there's seldom you see someone with anxiety that doesn't have depression, even though there are some of those. But they're usually closely linked. And it's not surprising that we use mostly the same medicines. I've been kind of slow in my life to get on board about some of the more subtle manifestations of anxiety, or actually not so subtle. Kids, aggressive kids, angry kids, a lot of that can flow out of anxiety. My own life experience is it's taken me about 60-some years now to realize how much issues I have with anger actually have flowed through the years from anxiety. I've learned that from my patients about myself. So we have to be attuned to anxiety with all our patients. And so the treatment of anxiety, the treatment of choice for all anxiety, adults and kids, with medication is antidepressant medications. Now, almost every time you look at research, they say medication is as effective and vice versa as psychotherapy. And of course, you guys probably know that about all they research nowadays is CBT and DBT, and that's kind of the standard for research. So they always refer to those types of psychotherapy. So medication and psychotherapy are pretty equally effective, and the combination is better than either alone. That's the standard feeling about the treatment, and that's true in most research. So I've listed all the different anxiety diagnoses. A couple stand out. Phobias don't do well with medicine. They're pretty much a therapy thing. Phobias that are associated with other anxiety, will work well. So I have several kids who are afraid of bugs, and so they don't go outside all summer. That specific phobia probably won't get better, but if they're kids who also have a lot of underlying anxiety, then that'll get better with treatment of medications. And most of the ones I've had have been that way. The other thing to comment about is obsessive compulsive disorder has flown the coop from anxiety. It used to be an anxiety disorder, but they decided a couple years ago it's not. It has its own separate place. And there are some subtleties in the different treatment, and we'll get to that here at the end. And by the way, hands can go up anytime. Any comments or anything, that's fine. It's more of a discussion, hopefully, than a lecture. So the treatment of choice, medication-wise, is antidepressant medications. And there's a simple algorithm that we follow. We usually start with an SSRI. Not written in stone, we don't have to, but we usually do, and we can use one of those. If it doesn't work for us, going to a second SSRI, which are our most common antidepressants, is completely valid. One may work perfectly fine while another one doesn't. Once again, bringing up, whether or not serotonin is the issue or the specific drug. And the reason a medicine might fail is because you've pushed it either up to the usual limit and it's just not going to work, or often side effects limit us, and that's when we have to move on. After we tried a couple SSRIs, if they're not working, we can go to either an SNRI or Wellbutrin. Wellbutrin is one of my really favorite antidepressants. The common understanding of Wellbutrin is it's a very energizing antidepressant. So standalone anxiety doesn't do so well, but anxiety that's associated with depression does well with it, and I use it a lot. I think teenagers do well with it, and surprisingly, I think teenage girls do well with it, and they're happy to hear it's not one that causes weight gain. I always digress into the history of these things because I've had the advantage of seeing a lot of the history, but Wellbutrin's an interesting medication. They were looking for a medication other than the old tricyclics. Tricyclics were what was there when I started. Nortriptyline was like the hot drug when I got started in this business. So. And they were very dangerous medicines. Overdoses on tricyclics are very dangerous. We're looking for a whole new group of medicines, and Wellbutrin was headed down the pike and was looked like it would be the first really successful of the new antidepressants. Because it doesn't cause weight gain, someone, I'm sure didn't last long with the company, got it in their head that, well, that would be a really good one for people with eating disorders because it's not going to cause them gain weight, they'll be more compliant with it. So they did, and a lot of them had seizures. We don't know why. It could have been a coincidence, but today you're not, there's a black box, don't give it to eating disorder patients because it can cause seizures. Well, they had to go back to the drawing board and redo their studies, and Prozac jumped right in front of them. And you know the story on Prozac, it's been incredibly successful. Wellbutrin should have been the star, and instead it was Prozac. So that's neither here. Yes?
Has there been, or do you know of any research that you could speak to in regard to hallucinations being a side effect of the Wellbutrin?
No research. I've not seen it.
Okay.
Yeah, I don't, and I've never, in my continuing medical education, I don't hear a lot of warnings about it.
I was just wondering if that would have been, like with the seizures for the eating disorders, if the reason that, if the hallucinations would be specifically to the eating disorders.
No, I'm sorry, did I say hallucinations?
I'm wondering.
You did, yeah.
Because I've had experience with Wellbutrin causing hallucinations, so I'm wondering if an eating disorder causing the seizures would also, if that made it a higher risk than the general population.
I don't know.
Sure.
I have no answer for that, no. So, yeah, after your serotonin reuptake inhibitors, if they've failed you, you can do Wellbutrin or you can do the SNRIs. And I've listed them. They're some of the newer ones, especially Effexor is commonly used. Effexor has, does anyone know what the problem with Effexor is? Well, yeah, weight gain, nausea, but it has a horrible discontinuation syndrome. People who get put on Effexor, if they're on any sort of decent dose for any length of time, about half of them go through a heck of a time getting off of it. And I guess it's quite miserable. The only other medicine that has a real significant discontinuation syndrome is paroxetine or Paxil. Both of them are very hard to get off of for half the people. I mean, I have all sorts of patients I've had on Effexor for years. They show up in the office, I quit my Effexor, and no problems. But a lot of people have a bad time with that. So I've put that second now to Cymbalta as my SNRI. Choosing which antidepressant, there's no good way to choose. The first thing I ask is for family history. Most people who are experts say, if it's 50-50, well, that can make it 51-49 on how to choose. If there's a family member who's done well with an specific antidepressant. So that's always my first question when we've come to the point that we've agreed to treat the anxiety with an antidepressant. And it's usually the way I go, unless it's something I don't like Paxil or Effexor or something that there's a good reason not to use. Or if the patient has a seizure disorder, you don't use Wellbutrin even if mom does well with Wellbutrin. But for the most part, that's a good guide. Probably a good time to put in my 2 cents worth on genotype testing. I'm really not a fan of that at all. A really big not fan, if there's such a thing about that, like that. I think, well, I just don't think it's useful. I think it's expensive, and I think there's a lot of red herrings with it also. What genotype testing does is show us, based on certain genotypes, how fast people will metabolize certain medicines by knowing what part of the liver or enzymes those medicines use. And so it will give us an idea of the relative blood levels that patient may have. The problem is, we don't know whether a person will do well with a high blood level or a low blood level. There's been no correlation between blood levels and response. So it's really not very useful. And any use it has compares class to class. By that I mean, if, say, Prozac on genotype testing by their algorithm has a better profile than, say, Wellbutrin, but you want to use Wellbutrin because the kid's sleeping 18 hours a day and you want to give them something that energizes them, well, you know, don't go with the genotype testing, go with what you think is a good medicine. And to digress from anxiety, if you have, I mean, how often is it that we're really, does this kid have, you know, just irritable depression, or is the reason he's beating up the school liaison officer because he has more of a bipolar disorder? Do we want an antidepressant? Do we want a mood stabilizer? Well, genotype testing is not going to help you there because they're just totally different medicines and totally different classes with totally different reasons to use. So I don't like genotype testing. I ran that by my mentor, who's currently chairman of the department at WashU, and they came to him, the folks from, and that all's come out of Rochester, Minnesota, all this genotype testing, and they asked him about it, him being a leading expert on thought and psychiatry, and he told them it was worthless, but nonetheless. Also, once again, going back to years of experience, I've seen a lot come and go. And every time we come up with some sort of biological test or this, they hang around for a while and then they go away and are proven not to be effective. So I don't buy into anything very quickly. So why don't we look at some of the specific antidepressants. My first choice very often is Lexapro. It has minimal side effects. Can have, these all, except Wellbutrin, can have sexual side effects. Only starts becoming an issue as our kids get older, but they can lower libido, decrease sexual performance, decrease erections in males. Lexapro's not too bad with that. Lexapro and citalopram are very, very similar medicines. In fact, they are just different isomers. Any of you who've had the privilege of taking biochemistry know that there are some molecules come in left and right isomers, and they're mirror images, so the atoms are in the same order, put together the same way, but are mirror images, strangely enough. They have different properties. In biochemistry, you can separate them by freezing, you can separate them by distilling. So citalopram is the right and left isomer of that molecule, where Lexapro, or S-citalopram, is the left-handed refined isomer. Lexapro is about twice as potent. I think it seems a little better, but the big deal nowadays is citalopram's received a lot of press about causing QTc elongation, the spreading out of the last part of the EKG, which can cause sudden death if it's too long. It's been a big deal, probably much bigger deal than it really needs to be. Lexapro does that less. The pharmacists will still be worried about high doses of Lexapro, but it seems like most of the experts are much more willing to use that at a higher dose than they will citalopram. Dose range on Lexapro, 5 to 20 milligrams, citalopram, 10 to 40. Sertraline's been around a long time. It's the most studied along with fluoxetine or Prozac for anxiety among children and adolescents. So it's commonly, one of my first choices. It's well tolerated. Fluoxetine's been around the longest. It tends to be kind of activating. You may have noticed in your kids that people have put on fluoxetine. You hear a little more often that it made their kid agitated. It tends to do that. I tend to stay away from it. Primaries still use a lot of it. And there's nothing wrong with that. It's got a good database. It just is a little more energizing and can cause agitation among some of the younger people that we work with. We talked about the concerns with paroxetine, a lot of weight gain, a lot of sedation, and that terrible withdrawal. Mirtazopine's used a little less often. It works on a slightly different serotonin receptor. It's really bad for weight gain, but some of our kids, and especially our ADD kids, need a little weight gain from their stimulants. I'll actually sometimes throw it on for no reason other than to help some of these really skinny kids on Vyvanse gain weight. Don't like to do that. I don't like to chase side effects, but sometimes it's about all we got left. But it's somewhat limited due to weight gain and sedation. It's used in nursing home a lot where people quit eating. They'll use that. But it's good for anxiety. It's just pretty limited in its use. We talked some about Wellbutrin. Seems to work. Some people say norepinephrine, some people say dopamine, some people say both. And I say, who knows? But it's very different. It's unique. And once again, it's so energizing. That's its claim to fame. The NSRIs, we talked a little bit about, yes?
When you say energizing, before when you were talking about another medication, you said it was energizing as in agitating.
Yeah.
Wellbutrin, are you using it the same way?
No, I'm not, and that's a good question. Probably sloppy terminology. Fluoxetine can be energizing, and sometimes I use it for low energy patients, but it tends to give, especially younger kids, tends more to make them agitated. Now, Wellbutrin, and I tend to use that with teenagers, the girls who are sleeping 18 hours a day, and it tends to give them more energy. It can cause, in fact, all the antidepressants can cause agitation, especially among our younger kids, our preteens. But I don't see that as much of the agitation. By that I mean getting angry, irritable, upset, versus just having more get up and go and motivation. Does that clear that up? Kind of, yeah, it does. Okay, yeah, it was. You're right. I was using the same term to mean two different things.
Dr.
Yeah.
Smith, do you ever prescribe like a Wellbutrin as well as like an SSRI?
Yeah, absolutely.
What is the benefit of that?
Well, usually I only go to two. Okay, let's kind of start on how that progresses. Most experts. So someone comes in, they're depressed, they're anxious, and you give them Lexapro. And you start at 5, and you see them next month, you get up to 10, and they're feeling better. Their depression's definitely better. They're still kind of tired a lot. They're still anxious. We go to 15. We go to 20. They're half-baked. In other words, they're 80% better than they were when they started, but there's 20% from who they want to be, from who they were before they got sick. So this is what I tell parents. I say we can do one of a couple things. One, you're 80% better. You're seeing a therapist. They'll fix you right up. So we'll just keep things the same, okay? And I do this all the time. I'll go 1, 2, 3, 4, and I'll just, well, so we can throw it all on the table and we can discuss. 2, Lexapro hasn't gotten us where we want to go. We can change. However, we're going to lose the benefit we gained. Maybe we'll do better with the next one, but we're going to lose that. And that's kind of like throwing the baby out with the bathwater. Or 3, we can add an additional medicine, which is what most people think you should do. So I say, I'm not real thrilled that they got to be on 2 antidepressants, but it's a better choice than getting rid of the thing that's gotten us 80% of the way home. So that's kind of how you arrive at more than 1 antidepressant. Especially, Lexapro, they're not as anxious, they're less depressed, they're still tired. And then maybe Wellbutrin. Maybe Cymbalta if they're less depressed but still very anxious. I like Cymbalta as an anti-anxiety antidepressant. It's usually that progression. I can't think that I would ever say, well, you got low energy but high anxiety, here's some Lexapro and Wellbutrin to start. That wouldn't be appropriate. And first of all, you try not to start 2 medicines at one time because you're going to get real confused if there's side effects, who's causing what. So that's how I usually arrive at 2 antidepressants. And then, of course, if the answer is first one's not helped at all, or you scratch it. And I leave it as a choice because, a lot of parents, I'll put my kid on more medicine, sure, more. But a lot of them are really 2 medicine, really didn't want the medicine in the first place, and now they got 2 medicines. So we really have this complete discussion like you and I are having right now in the office. There's another medicine under norepinephrine, serotonin reuptake inhibitors called Pristique. I'm very, very seldom used. It just didn't catch on. It's kind of like a long-acting Effexor. If you see someone on Pristique, their doctor uses genocyte testing. It seems to have the best profile on that. Every time I've seen it used in the last decade, it's because it had a good profile on genocyte testing. I hadn't seen it for ages, and then I work with the doctor at St. Elizabeth who uses the testing and keeps popping up on their med list. So, whatever that says. There are a couple new antidepressants. I've only had limited experience with them, mostly with my adult clients. I don't know. I didn't really introduce myself on my background or anything, but I do still see a day's worth of adults over at St. Elizabeth. So I've still got my hand in that, which, by the way, has been nice. I can bring all my 18-year-olds over there, so they don't get stuck out there with no one. So Vibrid works on slightly different serotonin receptor, works on dopamine and norepinephrine. It does affect the same serotonin receptor as Buspar, which is especially for anxiety. So it should, in theory, be very good for anxiety. I've just had limited use with it so far. Usually, like any new medicine, it gets used on the hardest of hard patients, so you don't always get that good a feel about it. And then Trinolix, which I've got a handful of patients on. Some have seemed to do real well with it. I don't think I've had any kids on it. Okay, so that's the antidepressants. Any questions about any of them? Those are the ones you see most. Okay, well, then there's Buspar. And Buspar first came out, it sounded like a good idea. Strictly an anti-anxiety medicine. Some GABA work, some serotonin work. Problem was it had no side effects, but it didn't work. Seems to be working now again. I think mainly because we used it on pretty hardcore adults, and especially with adults, once you've had a benzodiazepine, you ain't going back to something else. Once you've had the good stuff, you know, other things aren't going to be very helpful. And now with kids, I've been seeing a lot of Buspar used. I use it, I get response. I think a lot of the response here is in our 25% placebo range. I'll take that, but I've been using more of it, usually as an add-on, almost never as a frontline medicine. But antidepressant, their depression's better, their anxiety is 50% better. We'll throw on some Buspar. One drawback is really should be dosed 3 times a day. Well, there's no point in giving a teenager a 3-time-a-day medicine. It's just not going to happen. So we usually use it twice a day, but almost never a 1-time-a-day dosing. So, but it in theory should be a really good medicine. It's kind of weak. And then there's benzodiazepines. I don't know if I even put much here on that. Oh yeah, I can. I did. How about that? Very controversial among adults and kids. And of course, the reason for controversy is they can be abused, and they're sedating. And if you give them with narcotics, they can lower your respiratory drive. I probably have an adult who's not on benzodiazepines, but it's hard to find them. They seem to all end up on them. But with kids, that's a real tough decision. There are several reasons I will use them with kids. The main one is if they're not going to school, and the truancy court is getting riled up. That would be a time with a teenager to use a benzodiazepine as needed to get them to school in the morning, because that's a crisis. If your kid's just not going to school, you know, that is a major crisis, and you're in panic mode. And I have some kids who use those and use them well, and it helps them. Some I have them available at school for panic attacks. There's nothing better for a panic attack than a benzodiazepine. They're going to work well. Some people use hydroxyzine, an antihistamine, as an as-needed anxiety medicine. Once again, I think most of the response you get for hydroxyzine is in our placebo number, but it does help with some people. And they're all sedating. The hydroxyzine sedating, the benzodiazepines are sedating. And then, assuming you guys have seen most of these medicines come along, but benzodiazepines, they're your Xanax, aka alprazolam, Klonopin, aka clonazepam. And with kids, you most likely are going to see lorazepam, aka Ativan. So that's, in talking about anxiety, that's how they're used. In adults, you often have to gravitate to a routine dosing. In other words, 3 times a day regularly. You very seldom do that with kids. And I had a call day covering for Dr. Roof, who's apparently for agitation and anger is on routine dosing of Xanax and doing well. So there's some odd things that you run across after you've tried and tried and tried stuff. But that's kind of where it's at with the benzodiazepines. Got to be very, very cautious with their use. Anti-epileptic drugs have been getting used for anxiety. Gabapentin, oxcarbazepine, and Topamax. They all have a little bit of sedating properties. They seem to do pretty well for some people with anxiety, are kind of down to around a third line drug, although some people use them more often. Topamax is particularly problematic. Does anyone know the nickname for Topamax? Dopamax, because it can really interfere with cognition for a lot of people and makes them feel not dopey, well, it does make them feel dopey in the sedated sense, but just really seems to affect people's cognition. So if you ever see someone on Topamax, because you'll see it a lot for headaches. And you gotta be careful with that one. Some people do fine on it, other people get that issue. So those are sometimes used when you're running low on choices. You'll see a lot of antipsychotics used for depression and anxiety, and boy, they should be way at the end of your list. Antipsychotic medicines, Seroquel, Abilify, Risperdal, Geodon, Latuda, have a lot of long-term problems. The antidepressants, you get side effects, you get them, and then you either tolerate them or don't use them, but there's nothing down the pipe, nothing disastrous after years and years of use. With antipsychotics, there is. There's high blood sugars, frank diabetes, severe weight gain with most of them, except for Geodon, and they came out as medicines that aren't going to give you EPS or tardive dyskinesia, but they do. Not as often, but they do. EPS, that's for extrapyramidal symptoms. There are several manifestations of that. There's Parkinsonian symptoms. Looks like someone with Parkinson's disease. Patient can get that from them. There's acute dystonias, which you don't see as often with the new antipsychotics, which is muscle spasms, usually in the neck and in the jaw. So someone will come to you and go, I think I got something wrong with me, and that's a dystonia from the antipsychotics. Our old ones, Haldol, Novain, trifluoperazine, they did that all the time. These do it rarely, but they do it. The thing you don't want is tardive dyskinesia. The problem with tardive dyskinesia, and tardive means delayed, so this is something that usually comes on after a long, long time, probably after your kids turned 18 and gone on to someone else. But it's really bad. There's no treatment for it, and if you stop the medicine, it goes away half the time. It presents as not this is Parkinson's, this is tardive dyskinesia, and you see it in the mouth, that sort of stuff. Slow, a lot of times tongue movements, mouth movements, and it can be debilitating. Back in the old days when we had the old ones, we saw it a lot. But it can happen with the new ones, and people don't appreciate that. I use a lot of antipsychotics, usually as mood stabilizers in this business, and if they're psychotic, if they're hallucinating, you have no choice. That's what you got. But they should be down the list. It's one thing that it can be frustrating, but it's one thing I think that Medicaid here has done correct. They make it very, very, very hard to get benzodiazepines for you're 8 years old and under. And it's really a pain in the butt, and we all hate the government telling us how to practice medicine. But these medicines were run away and being used on all sorts of people. At Winnebago State Hospital, when you walk in, there's a machine. You put in quarters and you turn it, and Abilify comes out. No, that's not true. But I kind of assumed that because everyone walked out of there with Abilify. Well, that's not true. Some people crawled out of there on Abilify. I've had kids who literally could not stand because they went. It takes me months. If someone needs Abilify to get to 30 milligrams, they go in for a week stay and they come out in 30. Someone over there loves that stuff. And anyways, be careful with antipsychotics. I mean, you don't prescribe them, but I know you guys look at what medicines these kids are on, and yeah.
Do you still use Cogentin?
Yeah, you can use Cogentin Cogentin doesn't work for tardive dyskinesia. Oh, and thank you. That brings to mind something else. So it won't help with that. It'll help with the Parkinson's, the shakiness, and of course the acute dystonias. And we're more likely to see that in the hospital where we push things up. Back in the old days, before they came out with the new group started with Risperdal, which has kind of a foot in the old group and foot in the new group. It's very much like Haldol, but has some serotonin effects, so they put it into the new generation. But anyways, everything after Risperdal, then came Seroquel, then came Zyprexa, which puts 20 to 30 pounds on you almost automatic and is really reserved for other things. Then Geodon, and then now some of the newer ones, Latuda and a few others I don't use and don't come to mind. So the old ones, if we were going to put someone on any sort of significant dose, we'd just prescribe Cogentin along with it. It'd be like a dual medicine. And that would be to prevent, and Cogentin can treat, Artane also can treat the dystonias. Also, Amantadine will help, especially with the Parkinsonian symptoms. And nice thing about Amantadine, it's anti-flu medicine, so they don't get the flu either, and they quit shaking. So that's one that not too many people use. So that's kind of a bit of a rant about antipsychotics. Yeah.
I think I saw on TV some boys were suing because they had used Risperdal and it had increased their breast growth.
Yeah, it does. Risperdal is one to stay away from because one, the weight gain, plus its effect on prolactin levels. With boys, they grow breasts. With girls, they lactate. So you give a girl, at least a girl who's past menarche, there's a good chance they'll start lactating, which kind of freaks them out. And I've had a few people, females who just, that's all that they work for them, and kind of had to work around that. But I almost never prescribe Risperdal. Before Abilify became affordable, and a generic, I used a lot of Risperdal. But Abilify is a good antipsychotic as a mood stabilizer. Seroquel's used a lot, but it makes you tired. And it's nice because it'll help kids sleep, but if you get very much of it, it'll make them too tired during the day. And some people use it as a sleeping pill, and so all that, I just had to say, really goes double for using it as a sleeping pill because there's a lot better choices. And then OCD, which has escaped from the part of the DSM that has anxiety diagnosis, is a little bit different, and it's a good story. When I started in the business, people with OCD were pretty much doomed. Mild OCD responds pretty well to therapy, cognitive behavioral therapy. There's certain paradigms for that. But when you get into severe OCD, life-destroying OCD, it takes me 10 minutes to get to that door because I have to walk over these squares just the right way. I can't go outside unless I wrap my feet in plastic. And then when I come home, I have to shower under a scalding hot shower. I have to wash all my clothes and, clean my shoes and everything because I got all those germs on them. These are people who just can't function because they're OCD. There was no good treatment for them. Modified what did they get in Cuckoo's Nest? Lobotomy. Modified lobotomies were still being used that would help some of these people. No medicines. And then clomipramine was invented, but had a lot of side effects. And it wasn't approved by the FDA. This was, most of you can't remember, before the internet. And so there was no Canadian pharmacy to get this from. So the only people who got treated for their OCD lived in Arizona, California, and the UP, because they could go to Canada. and get the medicine. So they were the only ones being treated. Then, finally, the United States approved clomipramine for OCD. And lo and behold, it wasn't weeks, maybe months, that we discovered Prozac worked too. And then by, logic, all the SSRIs worked. And so all of a sudden we went from nothing to a bunch of stuff. But there's a certain, once again, algorithm for treating OCD. Usually start with what I call one of the typical SSRIs. Wellbutrin and the SNRIs don't work well. So you try one of those because they have a lot less side effects than clomipramine. And then if one doesn't work, I usually try another one. You tend to push them to higher doses than you might for depression or anxiety. Say fluoxetine, you'll give 20, maybe 10, 20, maybe 40 for depression or anxiety, occasionally 60. Doses of 60 and 80 for OCD are very common, and it tends to take a while longer to work. Instead of coming back every month, I have them come back every 6 weeks to adjust the dose. So we try one or two of those. And then there's Luvox, fluvoxamine, which seems to have particularly good properties for OCD. But it's pretty sedating. That's why it's not first usually. And so we go to Luvox, and then we go back to the old principle. Did the fluoxetine help you at all or not? Well, yeah, I'm 60% better. Okay, do you want to switch to Luvox or add Luvox? Kind of that old paradigm that we did earlier. And then there's clomipramine, and that is by far and away the best, antidepressant, best treatment for OCD. It's a big gun, it works really well. It's a very dirty medicine. Increased rate of seizures, I haven't seen that, thank goodness, but it does. Weight gain, sedation, terrible dry mouth, constipation. Because it's one of the old tricyclics that has a lot of anticholinergic properties, and it's the anticholinergic properties causes that dry mouth, blurred vision, and constipation. But it works better than the others. And once again, fluoxetine, citalopram, Luvox didn't do anything. Clomipramine. Fluoxetine got me 80% of the way there. Added a little Nafranil to it, so you got the combination. So that's the special algorithm for OCD. Want to go back. What you reminded me of was there's another side effect to antipsychotics that I know I'm missing all the time, especially with little kids. It's called akathisia. And it's a tremendous restlessness. And to separate that from attention deficit is very, very hard. I had one kid that was easy who, it wasn't so much he was hyperactive, he would sit down in his chair in my office for 2 seconds, then he'd walk and he'd pace. And it was more than just, the hyperactivity. He just could not possibly be still. And sometimes you see it where not the bouncy leg, which is anxiety or ADHD, but the just constantly moving legs, even if they're sitting down. That one doesn't do well with that anticholinergic stuff. Inderall's about the only thing that treats that. So, as you can imagine, the problem is you've got an agitated kid with ADHD who's beating up the school liaison officer, so you give him Abilify. And he seems to be a little more agitated. His hyperactivity's through the roof. And I miss this probably 9 out of 10 times because I seldom diagnose akathisia, but they could very well have akathisia, that restlessness from the antipsychotic. And I don't keep that as far in front of my mind as I should. So obviously, you treat depression with antidepressants. So pretty much everything I said today applies to depression. If we have a few minutes, I can say a little bit more about what we can do with depression. So you've tried antidepressant after antidepressant, and they're not getting better. That's called resistant depression. And so at that point, we use boosters. Lithium is a booster for antidepressants. It'll make antidepressants work better. Lithium is the only medication that has ever been shown in good, solid research to actually lower the risk of suicide. We'll use thyroid. People can be normal thyroid, but thyroid will boost the antidepressant effect. You got to watch the thyroid level. You want them on the razor edge of hyperthyroid. In adult women, you have to be real careful because hyperthyroid can cause osteoporosis. But I use this commonly in adults, rarely, but I have used it in kids. Stimulants, great antidepressants. And I use them a lot with low energy depression. Once again, much more in adults, because by the time you've gone through all the antidepressants, they've turned 18 and somewhere else. But I do have some of my teenagers, and they really are very good boosters of antidepressants. Brain-injured mood disorders really respond well. And a lot of people recommended for people with mood disorder secondary to brain injury to use stimulants. Also, dementia patients with depression, stimulants are often recommended. And then, nothing to do with us because you can't use it in kids, but does anyone know what the best treatment for depression is? Absolute, proven, twice as good as any antidepressant, 3 times as good. What? Yeah, you're right. It is. And you're absolutely right. And for anxiety and depression, and I'm glad you mentioned that because I try to recommend that to all my patients. But what I was thinking of is ECT, shock treatments. So much better, but a real problem. And not very many of us do them. I was doing them up till a couple years ago. I do very few now. Just usually I had to get there 6:30 every day, and that's just too early to do ECT. But very good. You can't use them with kids, but I bring that up. But yeah, so non-pharmacological treatments of anxiety and depression, and absolute, by far the best non-pharmacological treatment is exercise. Some people recommend yoga, or someone tell me, what is it those Chinese people do in the park where they're doing this stuff? Tai Chi. That was horribly racist. And I didn't mean it that way, I just couldn't come up with the word.
I knew what you meant.
Yeah, you know what I meant. So those two things some people feel are especially good because they link mind and body. And so they're linking physical exercise with the body. I prefer resistance, weightlifting. I think that really gets the body going more than cardio. But yeah, that's probably one of the best things these kids can do. I'll tell kids, I said, you know, if I could get all my patients to exercise, I'd have to get a job at McDonald's because I don't have anything to do. It really makes a huge difference. Yeah.
How do you handle kids that come in with anxiety or depression that are self-medicating with marijuana?
Yeah, that's hard because I think it's pretty obvious that it works for a lot of people. And if there's a mood disorder, I usually tell them that, you know, marijuana might be okay for some people, but if you have a bad mood disorder, there's pretty good evidence that it's not going to be very good for you. But anxiety is a tough one. You know, I'll share with them things like it's illegal. and it's got your parents really pissed off. But, you know, you got to say those things, but floating in the back of my head, it's like, probably not a bad choice. So, but you really can't encourage it, and you have to discourage it to some extent, but I don't discourage it probably with the vigor that my parents would like me to.
Does it impact at all any of the way you prescribe? If you know maybe?
I don't know of any different that I would do there. And of course, everyone who's come in the office in the last year is on CBD oil. I mean, you know, used to be fish oil. Now everyone's on CBD oil. But yeah, you know, tell my son, you know, the horrible effects of being on the antidepressant and drinking. Well, it might make you a little more drowsy, and you probably shouldn't drink as much. Well, you know, they're thrilled to hear me tell that to their 16-year-old. Then I bring up, and by the way, you're not really supposed to drink because it's illegal. And the same thing with marijuana. You know, it's like, you know, well, explain to them, you know, the dangers of using marijuana with this. And I said, well, I don't know, it's probably not a good thing or something like that. That does not win the parent over. I have a pathological resistance to lying. It's like that movie, Liar, Liar. And I trip over that a lot in my life. So okay, yeah.
For some of these medications, let's say, you know, we've seen some good improvement and we're ready to discharge from therapy, like what's the recommendation usually of how long kids should stay on them before, you know, starting to wean off so we're not like pulling everything out from under them?
Right, yeah, super question. 5 years ago, counting from when they first started to do well, not when you first started screwing around with the medicine, but from when they started to do well, it was 6 months before you'd even consider it. Now it's a year. The recommendations is a year, so the short answer is a year. The longer answer is that's really when you can talk about it. The vast majority of my patients who've done well for a year aren't in any hurry to get off of them, and that's okay. Also, there may have been inadvertent experiments. Oh, I missed my medicine, or I thought I was doing well and I quit it for a month and I got anxious, I got depressed. Well, they're not in a big hurry to get off of it. I've been on my antidepressant for a year, I'm doing well, and next week I start up at the University of Madison, Wisconsin, or University of Wisconsin-Madison. Well, let's not stop it today, you know. It's not the time. So you have to look at opportunities. And I tell patients these are completely benign medicines on the long term. Don't be in a hurry. And surprisingly how few people really want to jump off of them. That's the long answer. Short answer is a year.